नहीं, that's a problem.
है ना?
नहीं आता है.
कुछ गड़बड़ है लेकिन इसमें आता है वैसे इधर नहीं आता.
चलो.
लॉक कर देना. इसके चाबी भी पड़ी है और भी पड़ा है. ठीक है. कमरा लॉक करना प्लीज.
सही है. आगे भी लगी है. ठीक. आवाज आ रही है?
जी आ रही है डॉक्टर साहब, आ रही है आपकी आवाज. स्टार्ट करें मैडम?
हाँ, स्टार्ट करें.
करना स्टार्ट करें आप? बस बच्चे एडमिट हो गए.
अच्छा ठीक है. Okay, hello everyone. This is Dr. Sabal Khairi. I'll be taking your class today. Dr. Asad had some, we swapped our classes. So basically I'll be taking his class today, right? So the topic of today is orbital trauma. And before we begin with orbital trauma, you should be aware of the boundaries of the eyeball, the walls that constitute the orbit. So the orbit comprises of the roof, the medial wall, the floor, and the lateral wall. The roof is made up of the orbital plate of frontal bone and the lesser wing of sphenoid. Then the lateral wall is made up of the greater wing of sphenoid and the zygomatic bone. The inferior wall is made up of the zygomatic bone, the maxillary and the palatine bone, and the medial wall is made up of the maxillary, the lacrimal, the ethmoid, and the sphenoid bone, right? Can you guys all hear me? If you can just let me know in chat if I'm audible to everybody. Okay, great. Now, what happens is that we're going to talk about orbital fracture, okay? So the bone of the orbit that is most susceptible to injury is actually the floor of the orbit, and it is the inferior medial part of the floor of the orbit. So when you get hit in the eye, that part of the wall, that means that the floor of the wall, it fractures and your eyeball recedes, right? So what you get is a sort of sunken eye, and it's called enophthalmos. Also, because you have the infraorbital nerve entrapped in that area, it can lead to infraorbital anesthesia. And sometimes you have the inferior rectus position there and the superior oblique position there, and that can get entrapped in the fracture, and it can result in diplopia when you attempt to look both up and down. So this kind of a diplopia is known as double vertical diplopia. Vertical because the image that you're seeing is appearing double, and it's appearing double vertically, okay, not horizontally. And double because you're seeing that double image when you look up as well as down. So when you have somebody who comes in with like a sunken eyeball and an ophthalmos along with a history of trauma, you need to look into whether there is a fracture present or not, because the possibility of it is there, right? And for that, you need to carry out a CT scan. Okay, so a CT scan enables you to see the bones of the orbit. Right, let me see if... Let me try to change the slide over here. Okay, so treatment is conservative if the fracture is less than half of the floor of the orbit, if enophthalmos is less than 2 millimeters, and if the diplopia is getting better, okay? However, if you have a patient who has worsening diplopia or fracture more than half the size of the orbit, and somebody who has enophthalmos more than 2 millimeters, then you need to look into surgery. And surgery is simply where you make an incision, you identify the defect, you reposition the entrapped tissue, and you put in something to repair the defect. And that something can be a range of substances. It can be Supramid, it can be Teflon, it can be sometimes as simple as an X-ray film can also be used to bridge the gap. Okay, so that's a surgical intervention. Okay, now the medial wall fracture. By the way, it's a really nice picture over here. You can see that we have the fracture of the floor of the orbit, right? And this particular eye was hit by a tennis ball, and the eye has gone back a bit in the orbit, and it is now about to sort of drop down into the maxillary area. A medial wall fracture sometimes accompanies the floor fracture. And the treatment, remember something, whenever there's like an orbital fracture, the treatment is more or less the same. You have to manage it conservatively. If you see that the patient is improving, diplopia is improving, there's no entrapped muscle, and the fracture size is not that much. But then you also have to go in surgically if you feel that there is worsening diplopia. And you know, the thing is, if your eyeball muscle gets entrapped in a fracture, one of the serious things that can happen is that it can induce bradycardia. And if you have bradycardia, then obviously it will need surgical intervention. Okay. Now, sometimes you also have a roof fracture. It is rare, but it can be associated with something quite sinister, which doesn't really occur when there's a floor fracture or a medial wall fracture. What can happen is that you can have fracture of the roof of the orbit and a CNS leak. That means that a CSF leak, sorry, that the cerebrospinal fluid can leak into the orbit, and that can be disastrous because it can lead to meningitis. And so we have to make sure that when we are doing a surgery on the repair of the roof of the orbit, we make sure that there is no CSF leak. And it is common sense that if you have a roof fracture, the eyeball will be displaced inferiorly. Lateral wall fracture is rare because it is the sturdiest of all the walls. And a lateral wall fracture will occur if there is massive or extensive injury of the face, and then yes, lateral wall fracture can occur. Now, trauma of the globe is divided into blunt, penetrating, and perforating. Blunt trauma is when you get hit by an object that is usually larger than the size of the eyeball, and it causes a contracoup injury, and it causes compression of the eyeball anterior, posteriorly, and expansion laterally. So any eye structure can be damaged in blunt trauma. I'll come to that in a bit. Penetrating injury is when a foreign body lodges into the eye and it is found impacted somewhere in some part of the eye. While a perforating injury is one that enters into the eye and exits out from another. So basically you'll have an entry wound as well as an exit wound. You need to, when somebody comes in with a foreign body injury, a penetrating injury or perforating injury, in your history, you need to implore about the nature of the foreign body, the speed at which it hit the eye, the size of the foreign body. Was there any immediate treatment administered? Was there any investigation carried out? So the investigations that need to be carried out can include a plain X-ray if you don't have the facility of a CT scan. You can do a CT scan. You can do an ultrasound of the eye if the cornea is really opaque or if the lens is cataractous and you're not able to see the fundus. And you can do an electroretinogram too, which tells you about the integrity and the function of the photoreceptors of the eye. So simply put, it tells you about the status of the retina. If you have a foreign body impacted in the retina, you can do an ERG and it will tell you how healthy your retina is. Now, if you look at this picture over here, what do you think has happened to the patient? Guys, tell me. The patient, lower lid laceration, excellent. Okay, so this is a lower lid laceration, and the lower lid is torn from the medial canthus, and it seems to be hanging down. So this is clearly, a very sharp injury. And although there appears to be a small subconjunctival hemorrhage inferiorly, the remaining eye, such as the cornea and the pupil, appear normal. The pupil is dilated, but that might be iatrogenic, right? Because you always dilate the patient to look at the fundus. Now, a blunt trauma injury can affect your lids. It can lead to bruising and enchymosis. It can lead to corneal abrasion. It can lead to corneal edema. There might be tears in the descendant membrane. Remember something, that a normal, healthy cornea is one that is transparent, right? And when you have a corneal injury, the cornea will be opaque, and that is something that you need to consider when somebody has a traumatic injury to the eye. Now, you can also get something which is known as a hyphema, and hyphema means blood in the anterior chamber. Okay. What do you think is happening to this particular patient over here? Sorry. Yes, there appears to be penetration. Where do you think is the foreign body? Can you guys see a foreign body which is impacted in between the lower lid and the eye globe? It could be a piece of wood or a piece of glass. Okay, now this picture over here. Okay, so the white arrow, there's a white arrow and then there's a black arrow. Can you guys tell? And who will now tell me what the white arrow signifies? What does this white arrow show? Right. So I have comments coming in from you guys. Basically, what you see, that white arrow is showing a foreign body. You know, that brown irregular shaped structure that you see, that is actually a foreign body. It's gone in through a corneal laceration and is now being found in the anterior chamber. And that black arrow below is showing blood in the anterior chamber. And another name of it is hyphema. Okay? So you can have traumatic mydriasis, and that appears to be the case in this particular patient where the pupil is dilated. You can also have the iris torn away from its root. It then creates another pupil, and that is known as iridodialysis. And the ciliary body, which is found right next to the iris, that can also get damaged. Now, what is the function of the ciliary body? What happens when there's trauma? How can it damage the ciliary body? Anybody? What is the function of ciliary body? Ciliary body causes aqueous humor production. So when there's trauma to the ciliary body, what happens is there's ciliary body shock, and the production of aqueous humor goes down, and the eye goes into hypotony. Hypotony means that it becomes shrunken and it sinks further into the orbit. Okay? What can happen to the lens? The lens may develop a cataract, there may be subluxation, or there may be dislocation. The vitreous may develop a vitreous hemorrhage or a posterior vitreous detachment. The retina may have retinal edema, there may be a retinal tear, there may be a macular hole, there may be choroidal rupture, there may be a retinal detachment. The optic nerve can also get affected. You know, this thing that you see with the hemorrhage, that's the optic disc. And you can get a neuropathy where your optic nerve gets damaged, or sometimes the optic nerve gets torn away from the globe, and that is known as optic nerve avulsion. I have a question here. What is subluxation? Now, the lens is suspended in the eye by zonules, like these fine fibrillary substances. And if some of them rupture and some of them remain intact, the lens tilts, right? And that is known as subluxation. While if all the zonules were to rupture, then the lens will completely be dislocated, and that is known as dislocation of lens. It will then be found in the anterior chamber or in the vitreous. Okay, so if I were to revise the injuries that occur in blunt trauma, starting off from the eyelids, they can be ecchymosis, bruising, lid edema, even lid laceration. In the cornea, you have a hazy cornea. In the conjunctiva, you can have a subconjunctival hemorrhage. In the anterior chamber, you can get a hyphema. When it comes to the pupil can be dilated or it can be constricted, depending upon whether the constricted pupil is damaged or the dilated pupil is damaged. You can have iridodialysis, which means the iris is torn away from its roots and you can get two pupils. The lens can develop a cataract, it may subluxate or it may dislocate. The vitreous may get a vitreous hemorrhage. The retina may have a retinal detachment. There may be retinal edema. Another name of it is commotio retinae. There may be a macular hole, that means a hole in the region of the macula. There may be retinal detachment. There may be rupture of the choroid. When it comes to the optic nerve, you can have an optic neuropathy or you can have an optic nerve avulsion, right? So this was a summary of what happens when there is blunt trauma. Moving on. Penetrating trauma is when you have something like a foreign body that goes inside the eye. Causes can be due to profession related, such as welders. They often get a foreign body injury. It can be assault too, and a penetrating injury will have a point of entry. So that point of entry can be the cornea, it can be the conjunctiva, or it can be sclera, right? And depending upon how far the foreign body entered into the eye, you may have a cataract. Say if it went and penetrated the lens, it will immediately induce a cataract. If it goes and it gets impacted in the retina, then you might have a retinal tear. So it all depends upon where and how far your foreign body goes into the eye. And if you have a wound, let's say you have a wound of entry into the cornea, you see a foreign body, the case that we saw where we had a large foreign body in the anterior chamber. Well, if you have a large foreign body in the anterior chamber, you know that it's entered in from somewhere, right? There has to be a point of entry. So it can be the cornea, the conjunctiva. And if it's cornea, then you need to see if the corneal wound is still gaping. I mean, if the wound lips have not approximated, then we need to suture it. And if they have self-sealed, or if the wound is old, then we still need to go and extract the foreign body because it will impair vision, right? The foreign body, similar to blunt injury trauma, can also induce a retinal tear and a retinal detachment. Now, some of the intraocular foreign bodies are inert, and some are very reactive and very hazardous and toxic to the eye. So the inert foreign bodies include those made of glass, plastic, gold, silver, platinum. These are all inert. And by inert, I mean that the foreign body can go inside your eye, but will not release toxic ions or free radicals and will not cause further damage to the eye. As opposed to this, you have certain foreign bodies which are very toxic to the eye, and they include iron and copper. Iron can lead to a condition known as ocular sidrosis, in which you have a secondary cataract, you can get a glaucoma, it can go and affect your retina and damage the photoreceptors. Then a more toxic component is copper. And copper accumulation in the eye can lead to the formation of a Kaiser-Fletcher ring, which is this brownish ring that you see on the cornea. in the descending layer of the cornea. You might see golden plaques on the retina. You might see a sunflower-shaped cataract. So when copper accumulates in the eye, that condition is known as chalcosis. When iron accumulates in the eye, that condition is known as ocular sidrosis. Management includes history, examination of the eye. You can do a CT scan to locate the foreign body. And remember something, when you suspect the presence of a metallic foreign body, never, ever, ever do an MRI, because the MRI will not only draw out the foreign body, but the eye as well when you're doing an MRI because of the magnetic waves, right? So once you've identified where the foreign body is, you make an incision near the limbus or anywhere close to the foreign body through the sclera, and you can extract the foreign body. If it's metallic, you remove it with a magnet. And if it's non-metallic, then you can remove it with a forceps. After you extracted it out, you can apply sutures. And that is about it. The one thing that they haven't mentioned in this presentation, which I would like you guys all to know because it's of importance, is that sometimes you have chemical injury to the eye, and chemicals can comprise of both acids and alkalis. Alkalis are more dangerous than acids. And with alkalis, what happens is that they keep penetrating the eye and they can cause a cataract. Chemical injury is managed such that when a patient comes to you with injury with an acid or alkali, now they can be people working in the lab, they can be people working with car batteries in which you have sulfuric acid. They can be people who are working with cement workers, because that's a type of alkali, it's calcium hydroxide. That can go into your eye and can damage it. So the one thing that you need to do immediately is wash the eye as much as you can with as much fluid as you can. Once you've done that, you can start the patient with topical antibiotics, topical steroids, topical antibiotics to basically prevent secondary infection, topical steroids to reduce inflammation, topical cycloplegics to decrease the pain, and then observe the patient. Then you need to see if the patient requires any surgery. If the cornea is completely damaged and beyond repair, it's completely white, then you can consider a corneal transplant, a couple of months after the injury when the inflammation has subsided considerably. So this is what you need to know about chemical injury. Sometimes what happens is that both the cornea and the conjunctiva have melted away, and in such a case you do a surgical procedure which is known as keratoprosthesis, right, where you try to replace the cornea and the conjunctiva both. Sometimes you have a very small focal wound in the cornea, just an abrasion or an ulcer, and that can be covered and repaired with an amniotic membrane that you take out from the placenta of any patient. Amniotic membrane is used extensively in the eye because it has great healing properties. Okay, so this brings us to the end of our lecture. If there are any questions, I'd be happy to answer them. Any questions, anyone? No? Oh, sorry, there is a question. The question is, what was the condition that happens when ciliary body is damaged? When your ciliary body is damaged, it can lead to a condition known as ciliary body shock, in which the intraocular pressure of the eye gets reduced and the eye's pressure decreases. It is no longer able to maintain the shape and it becomes hypotenuse. That means that the normal intraocular pressure, which is usually between 11 to 21, it now goes down to something like 6 or 7 millimeters of mercury in a traumatic eyeball. That is known as ciliary shock. Any other question?
हेलो जी डॉक्टर सबा, एंड करें मैडम?
जी। हाँ, मेरे ख्याल से ये लोग और कोई इनके पास सवाल है नहीं, तो मेरे ख्याल से खत्म कर देते हैं।
चलो मैडम, थैंक यू, अल्लाह हाफिज, टेक केयर।